So there are numerous substances involved in mediating this allergic response, as well as inflammation. We'll cover a few of them here. These principal chemical mediators are produced by mast cells and basophils, and they account for the wide range of allergic symptoms that we see. Histamine is the most profuse of these. It's very fast acting. It stimulates smooth muscle, glands, and eosinophils, and it's responsible for the wheel of flare reaction, the reddening around the outside of an injection site, as well as pruritus or itching and headache. Histamine is also responsible for the more severe reactions that can lead to anaphylaxis. These are things like hypotension, tachycardia, and circulatory failure that might come along with anaphylactic shock or a very severe allergic reaction. It can result in closure of the airway, which is the most dangerous. The effects of serotonin are relatively unclear, but they do complement those of histamine. Leukotrienes induce gradual, smooth muscle contraction. They used to be known as the slow-reacting substances of anaphylaxis when looking at an asthmatic response and the prolonged bronchospasm involved there. We also see platelet activating factor. This is a lipid with similar effects as histamine, but it's released by the white blood cells. Prostaglandins are inflammatory agents that are responsible for vasodilation and increased vascular permeability, are increased sensitivity to pain, as well as bronchoconstriction. And bradykinins are another molecule that have prolonged smooth muscle contraction in the bronchioles, and dilation of peripheral arterioles, as well as increased capillary permeability and increased mucus secretion. All of these are responses involved in the inflammatory response that can be due to allergies or other infections. Here are some of the symptoms that we see mediated by substances secreted from the granules in the mast cells. Prostaglandins, leukotrienes, are histamine, serotonin, and bradykinin. This is a great summary figure to keep track of what each of those do. Let's have a quick concept check before we move on. What is the isotype of antibody that's most directly involved in type 1 hypersensitivity? IgG, IgM, IgA, or IgE? Well, this is simple recall. We'll go with the IgE here. Now recall we recently covered that IgA is an important response whose development is brought about by experience in the birth canal. So IgE is the most directly involved in type 1 hypersensitivity. So the mechanisms that we've covered in type 1 hypersensitivities are basic to hay fever, allergic asthma, food allergies, drug allergies, eczema, and anaphylaxis. In this next section, we're going to cover the main characteristics of these conditions, their methods of detection, as well as methods of treatment. Hay fever is also known as allergic rhinitis. It's a seasonal reaction to inhaled pollen or molds, but it could be a chronic year-round reaction to a multitude of other inhalants. It targets the respiratory membranes, so we see the histamine response in the respiratory membranes, resulting in nasal congestion, sneezing, coughing, extra mucus secretions in the form of a runny nose, itchy red and teary eyes, and sometimes mild bronchoconstriction. Asthma can be much more serious. These are episodes of impaired breathing due to severe bronchoconstriction. The symptoms include shortness of breath, almost to the point of suffocation in some cases, wheezing, rales, or cough, as well as an inflamed respiratory tract. This is because the airways are extra sensitive or extra responsive to minute amounts of inhaled allergen. It could be also from food or some other stimuli such as infectious agents. This overreaction is to the allergy chemicals like leukotrienes and serotonin, and imbalances also in the nervous control of the respiratory smooth muscles. This is evidenced by the psychological response that also happens when the individual realizes that they're short on breath. Atopic dermatitis is where we have intense itchy, inflammatory conditions in the skin, otherwise known as eczema. Sensitization occurs here from either ingestion, inhalation, and occasionally skin contact with the allergen. This allergic response can begin in infancy and progress all the way through adulthood. In infancy, it begins with reddened, weeping, and encrusted skin, but as the individual becomes an adult, they experience more dry, scaly, or thickened skin. Most of this skin irritation occurs on the face, scalp, neck, and inner surfaces of the limbs and trunk. Ordinary diet contains a vast number of potentially allergenic compounds. Although the portal of entry is the gastrointestinal tract, these food allergies often affect the respiratory tract and the skin. The gastrointestinal symptoms that we see involve vomiting and diarrhea or abdominal pain, but there are other symptoms we might see on the skin, such as eczema and hives, or in the respiratory system, rhinitis and asthma, and occasionally food allergies like peanut allergies can result in anaphylaxis. The most common food allergens are peanuts and fish, cow's milk, eggs, shellfish, and soybeans. Most involve a classic food hypersensitivity involving the IgE mechanisms and degranulation of mast cells. However, not all food allergies involve this mechanism. Keep in mind that food allergies involve activation of the immune system, whereas food intolerances can elicit some symptoms but not the inflammatory response and are thus not actual allergies. We also may see drug allergies. In the advent of modern drug treatments, we've been able to provide many medical advances and treatments, but often drugs are foreign compounds themselves, and so they are capable of stimulating allergic reactions. Virtually any tissue can be affected, and the reactions range from mild atopic reactions to fatal anaphylaxis. Most commonly, we see drugs like penicillin or sulfa-based drugs, aspirin, opiates, and then contrast dyes used in X-rays eliciting allergic responses. It's usually not the actual allergen itself, but a hapten that's given off by the liver as it processes that particular drug. So that hapten then binds to another molecule and elicits its response in that pathway. Finally, anaphylaxis. Anaphylaxis is a hugely overpowering systemic reaction. There are two clinical types of anaphylaxis seen in humans. There's cutaneous anaphylaxis. This is where we see the wheel of flare, an inflammatory reaction to the local injection of allergen. It's the red areas surrounding the bite or injection site within the first 20 minutes. Then we might see systemic anaphylaxis, which is where we have a sudden respiratory or circulatory disruption that can be fatal. Cutaneous anaphylaxis may lead to systemic anaphylaxis, but not necessarily. Either way, once it becomes systemic, we have a greatly amplified response of chemical mediators. And this response can be so fast that death can occur as quickly as 15 minutes. The allergen's portal of entry can be really variable, but most often we see it from things like bee stings or injection of antibiotics or serums that are a component of other injectable medications. Because allergy mimics infection, it's important for us to establish the cause. So allergy diagnosis involves several different tests, including non-specific, specific, in vitro, as in glass, and in vivo, in the living body methods. The in vitro methods involve measuring elevated blood levels of tryptase. Tryptase is an enzyme that's released by mast cells that is increasing during the allergic response. We can also measure differential blood cell count. We can also measure leukocyte histamine release. The leukocyte test measures the amount of histamine released from basophils when they're exposed to a specific allergen. There are also a number of serological tests that measure the levels of IgE when the individual is exposed to a specific antigen. There are also skin testing techniques where the patient's skin is injected or scratched or pricked with a small amount of a pure allergen extract. Allergists can use this map on either the individual's arm or on their back to map particular allergies in that individual. Each site is appraised for a wheel of response, as in a red circle of swelling and redness, after approximately 20 minutes. The one disadvantage is this test is not really reliable for food allergens. Now, how do we treat or prevent allergies? First of all, we can avoid the allergen or take drugs that block the action of the lymphocytes, mast cells, or chemical mediators. Vaccines can be used to short-circuit the allergic reaction. Or we can do desensitization therapy through the use of these vaccine-related drugs. The whole point of drugs is to block the progress of the allergic response between the IgE production and the symptoms. So let's take a look at that. In this figure, we can see the allergens come along. If we can break the cycle here and avoid the allergens, then there's no response. However, if the allergen reaches the plasma cells, then the plasma cells are going to produce plenty of IgE. We could use corticosteroids to inhibit the lymphocytes. This actually keeps the plasma cell from synthesizing any IgB and inhibits T cells. But if the IgE is made, then we have a mast cell that has IgE labels on them. We can use things like antihistamines to interfere with this response, or aspirin, or epinephrine, leukotriene inhibitors. Cromolyn is a drug that will prevent the degranulation of mast cells, so they never release any of those modulators of the immune response. Again, there are drugs that block the synthesis of leukotrienes and inactivate the IgEs. And then epinephrine, simply used to open the airways and create more space and prevent airways from closing. Finally, we can use allergy vaccines. They're not really vaccines, but they're controlled injections of the antigen. This is the desensitization therapy. It works by producing IgG antibodies rather than IgE antibodies. If there's a very small injection of the antigen, then the response is much slower, allowing for the IgG to bind these allergens. And thus we see no actual reaction with the mast cells because we don't see production of IgE. Let's have a quick concept check before we move on. What's the main mechanism of cromolyn action? And this one's a simple recall, but it may be a little bit tough to recall. Does it block T cell activation, block degranulation, block histamine receptors, or block IgE from binding? Let's take a quick look back at this image. This is where the cromolyn comes into play. So we're blocking the degranulation process. If none of those mediators are released, then we can have no response. So we'll choose B here.